And now with Dr. Camela Coppola, OBGYN consultant at the Department of Clinical and Community Health Services, University of Milan, Italy. Welcome, Dr. Camela. She will talk to us about sonographic criteria to assess residual placental tissue and appropriate hysteroscopic treatment versus medical treatment.
Thanks. I'm a pleasure to be here in this Congress, and I would like to thank the Congress organization. So my topics is the residual placental tissue and sonographic criteria to assess an hysteroscopic treatment versus medical treatment. Before starting, we remind the definition that is retained product of conception is a trophoblastic tissue persisting after delivery or termination of pregnancy. Into 2017, Sonier introduced a time after which we can talk about a retained of trophoblastic tissue, that is the menstruation period. The incidence is 1 up to 5% of all pregnancy, and the major part is present after the second delivery. We can have the early complication that is the hemorrhagia. It's very important to have a differential diagnosis with uterine vascular abnormality, arteriovenous malformation, pseudoaneurysm, subinvolution of placental site, and gestational trophoblastic disease. But we have also a late complication that are the uterine adhesion and the syndrome of Asherman that gave to the patient abnormal bleeding, hypermenorrhea, infertility, recurrent pregnancy loss, ectopic pregnancy, placenta abnormalities, preterm delivery, hemorrhagia. We must mark that more than 19% of uterine adhesion result from DNC performed after obstetric complication, 60% after one DNC, 24% after a multiple DNC. The diagnosis remains a clinical challenge. The existence of residual placenta may be suspected based on clinical history with the patient having symptoms like vaginal bleeding, abdominal or pelvic pains or fever. Kamaya in 2009 described the first classification focused on vascularity of endometrium and myometrium from 0 type without endometrial vascularity to type 3 with a marked endometrial vascularity greater than in myometrium. The Gutenberg classification incorporated into the ultrasound the evaluation of vascularity and echogenicity of the tissue. So we start on type 0 with hypoechogenicity, vascular mass, type 2, different echogenicity with minimal or no vascularity, type 2, high vascularization mass confined into the cavity, and type 3, high vascularization mass with high vascularized myometrium. This is the correspective anatomical pathological findings: non-vascularity into endometrium, vascularity into endometrium less than in myometrium, some vascularity between endometrium and endometrium, more vascularity in type 3 than in endometrium. The therapeutic approach in use are expectant management, medical therapy, DNC, hysteroscopy removal, and uterine artery embolization. But at the moment, we don't have any guidelines. So the medical treatments have like objective to promote the expulsion with the uterine contractility or avoid the surgical procedure. The hormonal therapy as like objective, the promote to endometrial glands and spiral arterial underdevelopment. This study that is on the oral contraceptive pill with ethinyl estradiol and desogestrel has been proposed to 12 women with persisting retained product of conception. And this was used on early gestational, 8 weeks gestational with minimal to mid vaginal bleeding and no sign of infection. And the pills was done for 3 weeks. And out of 11 patients treated, 9 women, 65% successfully expeded the retained the product of conception. In 3 cases, did not resolve following, and so we can say that the study concluded with we can propose the medical treatment in the case with the women don't want to be exposed to the surgical therapy. Another kind of study that that evaluated the use of misoprostol for the treatment after 1 trimester, it allowed 16% of DNC. And misoprostol is most effective in the setting of retained product of conception if the primary treatment for miscarriage was expectant management, with the less success with the primary medical management and the primary surgical management. So for a long time, the retained product of conception was treated with a blind surgery, and actually a lot of center, the DNC is the first choice, but still the first choice still. But we must remember that the complication of DNC increase in the postpartum, in which the uterine muscle is less strong. And we must also take in mind that these women wishing to become again pregnant. So the complications are the uterine wall perforation, the incomplete management of retained product of conception, and the need to do another surgery. So increase the risk to do intrauterine adhesion. Hysteroscopy, that is a vision technology, has some benefit because we sometimes not did a cervical dilatation. We can have direct visualization and so the selective removal of pathologic tissue and save the mymetium. And we have also the hemostatic capacity. The limits are that is contraindicated in early postpartum. We need of surgical skills, and if you compare to DNC, the procedure is longer and is also more expensive. In no. I want to show you some videos in which one the patient get before 2 DNC. No, sorry, but it's before. No, it doesn't work. Sorry, I would like to show you how after some procedure of DNC, so blind technology, we can find also retained the product of conception, but the video doesn't work, sorry. And but we must talk also about the complications. So in this study, we show, sorry, but can you put the start presentation? Okay, sorry. The limits of this paper that I show you is that the doctor before it not evaluated the vascularity. So we have a high hemorrhagia and 8 cases of perforation. So in a not adherent retained product of conception, and so with a low vascular score, we can have the maintained of cleavage between residual placenta and myometrium. So we can use the loop without electronic topics, and electrosurgical hemostasis is not required. Electrosurgical slicing to clear the implantation site is not required. And it's very important to mark that after the curettage, the risk of retained product of conception increase. And we can have also a potential greater endometrial injuries in the patient. Another kind of surgery is with esteroscopic morcellation or the shaver. That is a safe and faster alternative than loop. They reduce the risk of intrauterine adhesion. It's safe and at the same time it's very faster. So in the adherent retained product of conception with high vascular score and often extended to myometrium with the low resistance, we lost the cleavage between residual placenta and myometrium, and we need to use the electrosurgical hemostasis is often required. Electrosurgical slicing for myometrium to clear implantation is frequently required, and we must always remember to take in mind before to exclude any arteriovenous malformation. I'm sorry, but the video doesn't working. Sorry. In this study, we saw how in the case of retained product of conception type 3 with high vascularization, we among this patient with a history of a previous uterine surgery is almost always reported. Abnormality adherent placenta may present and underlying etiology. And so the DNC should be management without caution, without hemostatic risk, expectant management, medical therapy, and uterine artery embolization, or in some cases, hysterectomy may be considered. This interesting study gives us another help to evaluate the before and decide the SOD approach, that is the peak systolic velocity. In a case where we can find a PCV more 16 centimeter per second, we must suspect a big loss. And so we must prevent with the surgery. I'm sorry again for the not working video. Grazie. And I'm very sorry because you lost the focus of. Sì, non parte nessuno. But you put all the yeah, but it's just all video. Yeah, but okay. Okay, in this case, it's interesting to see that also with the hysteroscopy, we can have some problem, especially when we don't know the vascularization before. This is a case of adherent lesion, and so we can see how we remove the portion that is intrauterine. And we can say that this is the Yalin modification of the tissue. When we go near to the myometrium, we can see that the cleavage is not possible to see clearly. So it's very important to go slowly, because there is a high risk of perforation. And if there are some bleedings, try to go again slowly to improve the pressure with the water. No panic, because the vessel is very, very bigger. So it's very important to see. And we can remember that with the increase of the pressure of the water, you can give an hemostatic pressure, and so have an help. Oh, okay. No, really. Okay. This one. Okay, this study talk about the experience on 31 patients with retained product of conception with high vascularization and low resistance, and PCV most of 16 centimeters per second of reversible uterine embolization with effective into 90% of case and 2 cases of hysterectomy. Okay, this is the case in which one we can find a big lesion and PCV more 49 centimeters per second, and we can see the effect of embolization after the treatment. And in this case, I'm sorry again, but I would like to show you how there is a modification of the vessel. So about the outcome of hysteroscopy, we can say that we can have in this review a complete resection in one procedure in 91%, a complication rate of 2%. We reduce the syndrome, the intrauterine syndrome, Asherman syndrome at 0.8%. And the live birth rate, clinical pregnancy rate, and pregnancy loss rate is very, very important to note. This is the long-term complication. The operative hysteroscopy is in a wide review that say that operative hysteroscopy may be a preferable surgical treatment. Intrauterine lesion were uncontrolled after dilatation and curettage compared with the hysteroscopic resection. And we have fever incomplete if we compare the technology of DNC and hysteroscopic removal. In this study regarding the use of anti-adhesion barrier gel, this lecture review concluded that are not significant difference observed with the use or not after an hysteroscopy or morcellation treatment. This is our application. So that resume how we treat at Mangiagalli the case of retained product of conception. And I say thank you, and I'm sorry again for the video.
Thanks, Dr. Camela, for this informative lecture. And are there any questions for Dr. Camela about the lecture? Any questions? Thank you. Okay.
Thank you, Mr. Professor. What is the maximum time for induction in second trimesteric miscarriage, intratrimestral base from second trimesteric miscarriage, from 12 to 28 weeks gestation with intratrimestral base? Because we have a case report in Jalal Hospital. A case was para 3, normal vaginal delivery, admitted to hospital with intrauterine fetal death about 21, 24 weeks, and was induced by misoprostol for 10 days, and ended by rupture uterus. You know, it's a very miserable case.
I'll show you the last. Okay. In our experience, we use misoprostol the day before, and then we do the surgery. And the major part of case, we use the embolization. So generally we don't use for a long of time misoprostol.
But here we use misoprostol successfully, but in first trimester, it's easy before 12 weeks, but after 12 to 28, it is a very bad.
We use before a surgery to have the contraction of the uterus on the vas. Yeah, we know, but this is our experience. We use generally the misoprostol, 18 4 pills, and then we do the surgery. So
surgery for intrauterine fetal death,
the day before. One day before.
So you do surgery, hysterotomy for intrauterine fetal death?
No, hysterectomy, hysteroscopy.
Hysteroscopy?
Hysteroscopy for removal.
For removal of the baby?
Yeah.
If it is 21?
Not for removal of the baby. Sorry, you say with the baby inside?
Intrauterine fetal death 24
No,
weeks.
okay, but this is the use that we have for retained product of conception after.
After delivery.
After the delivery. After, not before. This is another kind of a protocol.
Yes, yes. Thank you. Thank you.
Any more questions? Okay, thank you, Dr. Camela.